some fun and to try to be a IT guy for a second, and we're going to get started. So I'd like to thank Christy, Medtronic, and also in the background for this is one of our biggest fans, Joe Ragone, who's going to help us out with all of our InnerStim talks. So I just received word the other day that my ranking has dropped a little bit. I relocated to Atlanta 2 years ago, and my health grades went from 100% down to 93%. So it looks like I have a little bit of work to do. Today we're going to talk about overactive bladder. As a urologist, I am the doctor that helps people either pee more often or pee less often, depends on what their problem is. Our agenda is to say hello, understand what bladder control means, talk about a pathway or an algorithm that exists for overactive bladder, talk about some treatment options, and then specifically discuss the Medtronic bladder control therapy, also known as InnerStim. At the end, we're going to try to put together some questions, so if you have any questions, please list them in the question box in the lower right side of your screen, and we will do our very best to answer all of your questions. So, how does it work? The way the body is put together is we have a brain, we have a spinal cord. In the bottom of the spinal cord is a nucleus, and then nerves come out to head to our bladder. And so the bladder is very involved with the neurologic system. When something goes awry, whether it's prostate enlargement, whether it's dropped bladder, whether it's just from medications or something like diabetes, the bladder tends to become overactive. Overactive bladder means that the timing to go to the bathroom is off. You're going to start having to go to the bathroom more often. You may have to wake up numerous times at night to go to the bathroom, which then leads to exhaustion, and then being exhausted has its own downfall of other problems that we see in our office. And so and this just greatly affects our quality of life. It affects us to go out to dinner, even though we can't really go out to dinner these days. But if we're trying to watch a movie, we have to stop in the middle of the movie and get up and go to the bathroom. People who are watching baseball, football, or basketball games, they can't watch the winning shot or the home run in the bottom of the seventh because they're up getting to the restroom. So very, very common problem. Estimated 37 million people, 1 in 6 adults. As we talked about, it discusses loss of sleep, loss of confidence, loss of self-esteem. People are afraid to leave their house. People are afraid to know that they have to wear pads because of running to the bathroom so much. And so what's normal? What isn't normal? There is no normal, but there are some guidelines as to what is familiar. So going more than 8 times a day, that's not good. The feeling to have to run to the bathroom, in other words, you're in the middle of an activity and you just got to get up and leave, that's bad. People who plan their schedule, I have a lot of patients that they can tell me where the restrooms are when they're driving to work, if they're driving to work. Or they know where the restrooms are when they're in the mall. People have to be careful about going on a trip. In other words, if they're going to drive and see their kids or the grandkids and it's a 2-hour drive, they know that they have to restrict their fluids before they get in. And then, of course, they have to spend a lot of money on wearing pads because some of these people will leak because they can't get to the bathroom on time. So like we talked about, how does the bladder work? There's nerves that stimulate the spinal cord. The spinal cord sends signals down to the bladder. There is an eventual sensation to say, okay, it's time. We got to think about getting to the bathroom. But you can hopefully wait a few more minutes, maybe even a half hour. And you can say, I'll get to the bathroom in a little bit. I'll finish my gardening. I'll finish this show before the commercials come on. But when those signals get off and stop communicating properly, that's when we start getting this running to the bathroom in this overactive bladder. So What can we do? Let me back up for a second. What are some of the causes? So diet is a big one. Too much coffee, too much soda, spicy foods, irritating foods. That could be something that's very simple to correct. Medications, specifically diuretics, things like Lasix, hydrochlorothiazide, chlorothalidone. Some of the blood pressure medications can do it. Pregnancy, that's easy. The baby starts pushing down on the bladder. Or after pregnancy, the childbirth, it just injures the pelvic structures. The bladder gets off its axis, and the bladder starts acting on its own. And then pelvic floor issues, the muscles of the pelvis start getting involved as well. 3 common issues that we see in our office: stress incontinence. Stress incontinence means that you're laughing, sneezing, coughing, and it comes out. Retention means it's not coming out at all. You can't get to the bathroom. We tend to see that more with men with prostate enlargement. And then, as we're talking about today, this overactive bladder. Now, a lot of times urinary retention can actually lead to overactive bladder and stress incontinence, because if you think of the bladder like a sink, and this bladder starts to fill and fill and fill just like a sink fills, eventually you can get overflow. That would be like your stress incontinence. But if you have prolonged urinary retention, the bladder starts to get a mind of its own, and it starts squeezing on its own without any control. Stress incontinence, like we just talked about, leaking with coughing, laughing, sneezing, standing up. If anybody's been on a trampoline, that's another test. I attempted to put a small trampoline in my office and have people jump up and down, and we can see if they leak. They also have time to avoid trying to get up to having an accident. What is urinary retention? Like we just mentioned, the bladder's just not emptying. Bladder's filling up. Bladder will not empty out all the way. Mostly a guy problem from enlarged prostates, but we do see it in women. In some women, when they have a dropped bladder or a dropped uterus, it can actually kink the urinary symptoms, or the urinary system, and it prevents the bladder from emptying all the way. Also, we see it in people with diabetes, just like there's diabetic ophthalmology issues. In other words, they get issues with the eyes, diabetic neuropathies. We see diabetic cystopathies. And so these people need lots of medications. Sometimes they need to wear catheters or pass a catheter in a few times a day. And like I mentioned, it can lead to both stress and overactive bladder issues. And then, as we're specific for today, what is overactive bladder? So overactive bladder we can describe in 2 different scenarios. One, which is listed in the bottom here, this urgency frequency. In other words, you're going too much. You got this urge that you got to get to the bathroom immediately. You don't feel like you can control it. You're up at night 2, 3, 4, 5 times to get to the bathroom. And then there's urge incontinence. Urge incontinence means that you get that sensation, you start getting to the bathroom, but it's coming out before you can even get to the toilet. And as I mentioned, a lot of these people will wear pads, change their quality of life, restrict their fluid intake, or even just don't even go out, because if they're home, they are near their own bathroom. So the good news, it's treatable. So what do we do? So there's an algorithm that we have for this. The algorithm was actually written by a number of urologists. One of them happens to be from the Cleveland Clinic, where I was able to do some of my training. And so what do we do when people come into the office? And so the first is to recognize what the issue is. So if they have this overactive bladder, focus on it. Don't focus on something else like they may have a small kidney stone, but don't worry about that right now. Let's focus on the quality of life stuff. So the first thing we think about is the lifestyle changes. You know, are we drinking too much soda? How many cups of coffee are we having? What time do we take our diuretic medicines? Are we taking them at an improper time that's affecting our fluid movement in the body? And can we do exercises? There's something called Kegel exercises. That's basically when we're squeezing our pelvic muscles to hold in our urine. And in some people, that can actually be very effective. We have our patients try that for a while, a couple weeks. We see if that helps them. If it doesn't work, then we have medications. And there's two different kinds of medications that we use for overactive bladder. One are called anticholinergics. These are medications that slow the muscles down of the urinary system, but they also slow the muscles down in your eyes, in your gut, and some of them can actually get into the brain and cause side effects like confusion and lightheadedness, memory issues, and things like that. The big side effect of these medications are dry mouth, constipation. And then we have advanced therapies. Advanced therapies means that the lifestyle changes didn't work, the exercises didn't work, the medications didn't work, and it's time to move on to bigger and better things. And let me back up a second. There's also another medication that's newer, about 7-8 years on the market, and that is very selective for certain receptors in the bladder to help slow down the bladder contractions so that you don't have to run to the bathroom so much. Great medication, less side effect profile, but unfortunately not covered by insurances very often. So let's just hash that out again. Lifestyle changes, exercises, watch what we eat, reduce our caffeine, watch what time we drink our water and before we go out of the house. We will also send some people for biofeedback for pelvic floor physical therapy. We have excellent pelvic floor physical therapists here in the Sandy Springs and surrounding areas. And like I mentioned, Kegel exercises, which are squeezing your pelvic muscles to hold in your urine. Medications. So the medications I mentioned, anticholinergics, these are nice medicines filled with side effects. I mean, very high side effect profile. There are numerous studies which have shown that up to 60, 70, if not 80% of patients will stop these medications within 6 months because the side effects are so bad. So you help one situation, but now you have this person with blurred vision, dried mouth, they're constipated, maybe they're getting a little confused from it, and also very challenging in our elderly population. So then we have advanced therapies. One advanced therapy, which is listed here as the injected medication, is Botox. We love Botox. We put it here, we put it in our esophagus, we put it in our side of our temples for headaches, we use it for spasms of muscles and muscle contraction issues. And as we're mentioning today, we're talking a lot about the Medtronic bladder control system, which is the InnerStim, or you can call it like a bladder pacemaker. So the injected medicines, wonderful. They've been out for probably, I would say, well over 10 years now, if not close to 15 years now. Very simple office or surgical center-based procedure. We look inside the bladder if we think you're a proper candidate for it. We make these tiny injections of Botox into the bladder using a cystoscope. Takes all of 5 minutes. Patient goes home, and we wait about 7 to 10 days to see this medicine kick in. But there's issues with it. One issue is it might be too much. We tend to start with a certain amount of units. So for example, I believe when the dermatologists use Botox for like our forehead, you use about 10 units. In the bladder, we start with about 100 units, and we can go all the way up to 300 units. But for some people, that 100 units could be a little too much, and then in 6% of the population, they may actually stop urinating for a few weeks after the procedure. It's low risk, but it does happen. The other downside of Botox is it wears off, and we have to repeat it. Sometimes it gets repeated every 3 months. Sometimes it gets repeated up to about 18 months. But the InnerStim is we look at it as a more permanent approach. It is something that we're trying to get something that's more long-term, less fuss, and restore bladder function back to its baseline. So the way it works is once a patient works their way down the algorithm, and we feel that they're a candidate for this, we set them up for a test, an evaluation. It's almost like a Holter monitor for heart things. In other words, you see your cardiologist, there might be a little skipped beat, or there's a thought of atrial fibrillation, and you have to wear a Holter monitor for a couple of days so they can get an EKG on you for a few days. We do the same thing, slightly more invasive. we bring someone into our office or surgery center. They lay down, they're on their tummy, like they're getting ready to go to sleep. We clean the bottom of the sacrum, so just above the tush, and right below the spinal cord, and we clean the area and put numbing medicine near what's called the S3 nerve root. We've all heard of the L4, L5, L5, S1, L2, L3. Urologists work with S3 because that's where the nerves head down the spinal cord and head to the bladder through the pelvis. And what we do is we put these very tiny angel hair-like little wires next to the nerve. We then secure them to the skin with some clear tape, like the tape when you get a IV put in. It's called Tegaderm. And then there's a battery that actually looks a little bit like my iPod case, that actually it's a little bit smaller, and then that gets taped to the back. You wear this device for about 2 days, sometimes up to 5 days, depending on the situation, and you keep a log at home. We give you a log, how many times you have to use the restroom, is there a lot of urges, is the urging better, and do you think this is helping you? The reps, like Christy and Joe, who are in the background of this talk, they will be in touch with you during this test. They are there to answer your questions, make sure you're doing okay, and make sure that everything is meeting where it needs to go. 2, 3, 4, 5 days later, you come back into the office, lay down on your tummy, and we just gently pull the wires out, go home, take a shower, clean it off. And if this test was great, and what we do is we look at for a 50% or greater response, then we know that this modality is going to work for you. So if a patient comes back and they say to me, wow, that was amazing. Instead of waking up 3 times a night, I only woke up once. And instead of going to the bathroom 11 times, I only went to the bathroom 6 times. And instead of me having to wear 3 pads, I only wore 1 pad, or I didn't wear a pad at all. We can feel confident that this patient is going to do nicely. And so if they are going to do nicely, then we bring them back for the full implant. So what are the responses? 84% satisfaction, 76% of people felt success with it. We feel that it is a wonderful therapy for people with this situation. I'm going to go back a slide a second. So for the full implant, that means that we have to do this either in a surgery center or in the hospital. And sometimes that's insurance dependent or patient dependent. The full implant means that we're going to bring in, you're going to definitely get some sedation for this, and it's sedation like when you get a colonoscopy. Once again, you lay down on your tummy, we identify the S3 nerve root, numbing medicine goes inside, and then we X-ray the body so that we can see exactly where that nerve root is, and we place the wire in. Once the wire goes in and we test it, we make sure that it's in the proper space and proper location, the wire gets tunneled under the skin towards the glutes, and then we make a little incision that's about yay big, and we put the battery inside, just like someone would have a battery for a pacemaker. So cardiologists work here, I'm working down here. And we put the battery in, we connect it to the wire, we test it again, we put some dissolvable sutures, dissolvable skin, you go home. Ice pack for a couple of days, little Motrin for a couple of days, and this thing starts working instantly. And our experience is that it actually starts to get better as this starts to modulate and mold the nervous system to help with the bladder. What's new? So this is actually a nice time in the world of Medtronics, because the picture that you see here, you're going to see 2 different silver batteries. The big one is the one that we've been using for a long time now, X number of years, but that was never MRI compatible. And the smaller battery now is now MRI compatible with the MRI compatible wire. So in other words, when you have MRIs, there's certain things in your body that prevent you from getting an MRI. So people who have pacemakers here, they have to hope that it's MRI compatible. If they don't, then they can't have an MRI. Now we're fortunate that the new battery is safe to be to be used in MRI situations. So God forbid a person falls, they hurt their back, or they need MRIs of like their liver or their kidneys, they can now safely have the MRI. The other is that the small battery that you're seeing here is actually rechargeable. And so for about 20 minutes a week, a person just sits down. They have a little device that goes over the battery, almost like you're charging your wireless cell phone, and it charges the new battery over a period of 20 minutes. It's smaller, and that way we don't have to change the regular battery out, because the regular battery, what's listed here, the big one in the picture, that usually lasts anywhere around 5 years or so. And so at some point that has to be changed. Now it is easy to change. It is a simple little procedure of just opening up that little pocket that I made by the glutes, and I just open it, clean it, put a new battery in, and we're good to go. So actually in the world of urology, this was actually a very exciting week because this is what just came out. And our office, fortunately, was one of the first in the state to start using the new battery. One of the things, I'm just going to plug Advanced Urology for a second here. One of the things that we're very proud of is we actually have a navigator for our patients with overactive bladder. Her name is Nikki, and her entire job is to help our patients with this situation. She helps with the medications, she helps answer all the questions, she helps determine with insurances, she helps get people in touch with who they need to get in touch with, and that has been an absolute home run for our practice. We modeled it after some of the oncology practices, so when people have very complicated cancers, a lot of times there's a coordinator that helps patients with their navigation issues, make sure they're getting their blood work, make sure they're getting their chemo. Obviously this is a little different, but we have our navigator, Nikki, to help out. So how do you know if this is the right therapy for you? Well, you gotta think if you want to go to the doctor first, because for many, many, many years, patients would say, well, my mother had it, I'm just gonna deal with it the way my mother had it, which was not do anything. Or they said, my grandmother had it, she didn't do anything about it, I'm not going to do anything about it. Well, I leave that up to you. It's very fixable, but it does require some work. It does require going to the doctor. It does require some testing, but we can get this under control in many, many, many of our patients. And I'm not sure, we're going to play a little story here. Just give me a second.
My name is Sarah, and I'm a management consultant, and I'm 28 years old.
Hi, good morning, Sarah. You have some missed calls.
It's a lot of work, and I'm very much engaged in my career and where I'm going, and it's just very exciting right now. When I was about 17, I started noticing more frequency and the urgency coming on, and dealt with it through various forms of antibiotics and just different approaches with diet. And then it got worse and worse. I was really embarrassed when I first joined this company that I had this to deal with, and I actually called it bladderitis. I would get into work and attend a meeting and again be fine sitting down the minute that you stand up. Kind of embarrassing when you've got clients around and you've got to hightail it to the ladies' room. You just always felt like you had to go. It was not good. It was horrible. So how I was led up to InnerStim was through a physician referral that this was the last hope, basically, that I had. And I went in very skeptical, very reluctant, and very closed to this final idea.
The thing I remember most about Sarah is when she came to see me, she was miserable, first of all. She had tried numerous therapies. Everywhere she went, she was being ruled by her bladder symptom that was controlling her, was affecting her relationships. She is a professional who travels a lot. It was affecting her work. And when I saw her, she was essentially at the end of her rope. The best thing with Sarah that I remember is when I talked to her about the InnerStim, she was so skeptical.
I didn't understand why she was so sure that it would work, but given the high percentage rate, I was very open towards the end of our conversation. Given that there was a trial, I was very secure with the fact that it wasn't going to be permanent, that we could have that trial period. My test stimulation period was interesting. It involved a lot of different changes to my settings to try to figure out which one was going to work, and nothing seemed to be doing the trick until the day before the end of my trial, which was a great success for me because it took a little bit of time to settle in. So after the success of the trial, I decided to go ahead and have the second surgery for the implant, and have had no problem since. I love to run and was only really able to run short distances. Any movement to the bladder was just, would set you off with regards to feeling like you had to go to the bathroom. After InnerStim, it's like I never had that problem before. I can stay at the gym as long as I want, and I even ran a half marathon just because I didn't have to deal with that anymore. I think of all of the things, I am the most proud of that moment. 2 hours and 28 minutes and 13.1 miles in 20-degree weather. I did it because of InnerStim. I don't think I could have done it without it.
Excellent, excellent. Now give me a second here to just try to get back to where I need to be. Oh, I did it. Look at that. All right, so at this point, here's our office number, 678-344-8900. Many of you may know that already. I included my email here just in case someone wants to send me an email, but I will tell you that emails are not HIPAA compliant, so don't send me a lot of detailed information because it's really not a safe way to communicate with your physician. I am going to, I guess, turn this back over to Christy so that she can try to help with any of the questions and move forward from there. You're welcome. I got it. I see it here. So, can I take it, Christy? Okay, great. Thank you. All right. So, do you have to come into the office once per week to charge the battery after
This is a
receiving?
tomato. Think it's good for you?
Hold on.
Think
Something
again.
happened.
There's one simple trick to controlling your weight.
Cardiothoracic
Hold
surgeon
on.
Stephen Gundry
I
says
don't
he
know what's
solved
happening
the weight
here.
loss mystery.
You really have changed the way I think
I'm definitely
about
having
what
an
I eat.
audio
Best book
problem.
I've seen on diet ever.
If you've been struggling with your weight, I've got
I'm
the
going to stop
solution
sharing
for
my
you.
screen
People at home
for
right
a
now are
second.
saying, I cannot believe what I'm hearing.
Sound too good to be true? Well, Dr. Gundry is living proof that his
I think my YouTube, because that video went to YouTube, just acted up. I apologize for that. Can you still hear me, Christy? Christy, can you hear me now? Oh, okay, there we go. Yeah, I apologize for that. I think the YouTube just kept running, and then it just kept going in the background of my computer. I'm sorry. All right, so do you have to come into the office once per week to charge the battery after receiving the full implant? The answer is no. You'll be set up with a charger at home. It's a belt with a little device, and you just place it over where the device is in the backside, and you just sit there for 20 minutes and it charges. Next part of the question is, how do you test it during the implant procedure? So this is actually where the nervous system comes in. So when you are getting your test, whether you're under a little bit of sedation or you're awake and just given some Valium, when we put the wire in, we are going to stimulate the wire with a little bit of electricity, and we're actually going to watch your toe, your great toe, go up. And that tells us that we're actually affecting the S3 nerve root, because the S3, the hip bone's connected to the knee bone. So the nerve that also heads to the bladder is also part of the nerve that heads to the foot. And so we're able to link that and show that by moving that toe and actually seeing some other reflexes of the pelvic muscles that we're in the right spot. And the other thing to confirm is that it's also X-ray guided. So when we put the final implant in, we will do a series of X-rays with what's called a C-arm. C-arm is like what you do when you get your hip replaced, your knee operated on, things like that. We do it in urology as well. And we make sure that the wire is in a right spot. We make sure it's at a proper depth. And we make sure that there's an actual little curve that follows the root of the nerve out of the S3 nerve root. So I hope that answers your questions. It is available for both. So the InnerStim was actually invented for people who have urinary retention. That's the way it was designed, at least the way I read the publications and stuff. But what they realized over time, that it's far better for people who have overactive bladder. And so it's actually approved for both situations. When you have a bladder that just has a very little squeeze to it and we need that bladder to wake up, this is the best that we have so that people can get off catheters and using catheters to drain their bladder. For overactive bladder, it's the same idea. It's the same idea of stimulating the nervous system to calm the bladder down so that they don't have to go to the bathroom so much. Christy, did that answer the question? Good. What do I think about Eurolift? So Eurolift is for prostate enlargement. So that's for BPH, benign prostatic hyperplasia. So we are, like Christy said, a little bit off subject here. It's not involved with truly overactive bladder unless the overactive bladder is due to prostate enlargement. So this is not for women. Women don't have prostates. Eurolift is not for women. But if a man comes in and they have prostate enlargement and one of their big symptoms is an overactive bladder and they're just running to the bathroom so much, we're going to put them down the algorithm for prostate enlargement. That involves medications, exercises, dietary stuff, and then if I think that Eurolift is appropriate for them, then we're going to do that. If their prostate symptoms get better, in other words, their flow gets better, their emptying their bladder gets better, their weak stream gets better, perfect. But if they still have a lagging overactive bladder, urgency, waking at night, and we can prove that the retention is gone, the blockage from the prostate is gone, then some of those guys have to go on and consider the algorithm for overactive bladder, those medications, those dietary considerations, and InnerStim. And we do have numerous patients in our practice that have required both prostate procedures, both a prostate procedure, and then once we prove that they're urinating better, once they are flowing better, we then can put in an InnerStim if they still have overactive bladder. So the medicine so this is fun in the summertime because if you take these medicines and you pee in the pool, people will know it's you. That's my favorite joke. So the medicine that turns your pee orange, it used to be called pyridium. It's called phenazopyridium or something like that. And that is more of a topical Novocaine for the bladder. That is not going to help slow down urgency, frequency, and waking at night. The medicines that turn your pee like a green blue or greenish blue, there's a few on the market. One is called Urabel. One is called Eurogesic Blue. There's a generic version. It used to be called Proced, but I think that's off the market. That actually it's a combination medication, and one of the medications within it is called hyoscine. Hyoscine is actually a smooth muscle relaxant. It's been around for decades, and it used to be used very commonly for like spastic colons, people with irritable bowel syndromes, because if it slowed down the colon, people's irritation and bowel habits got better. And so it's also used for bladder conditions. I use it very commonly for certain conditions, specifically recurrent bladder infections and something called interstitial cystitis. Interstitial cystitis causes overactive bladder in numerous patients. And so I will use Eurogesic Blue very commonly for it, but it's really not the go-to medication or the go-to treatment for overactive bladder. And the downside of the medicines that turn your pee blue or green blue is that they're very expensive. I don't think I've ever seen an insurance cover it. Usually in the world of, well, I'll leave that. That's a different subject. Yes, that actually happened to a patient of mine. So I had a patient back in my Jersey practice who did a lot of business, had to travel in numerous places, and she would travel with her Urabel or Eurogesic Blue. I don't remember exactly what she was on. And once one of the capsules broke on a marble tile in the hotel and stained the marble tile, and she felt terrible. Yeah. No. So the two surgical options for overactive bladder, or if the medications are just not cutting it anymore and you're maxed out on the medications, are Botox, and let me see if I can actually go back. Yeah, so in this slide right here, injected medication, so that's Botox. So Botox is injected into the bladder muscle through a cystoscope. It takes about 7 to 10 days for the medication to kick in, and then its job is to slow the muscle down. Just like when you look at someone's forehead who's had a lot of Botox, it's nice and smooth because the muscles are nice and relaxed in the forehead. And then the second is the Medtronic InnerStim, and that's what we've been discussing here, and that's stimulating the nervous system to quiet down the bladder. I hope that answers that person's question. It was a little brief. So, unfortunately, there is no, I'm going to say, treatment for interstitial cystitis. There's no wonderful remedy for it because, unfortunately, we just don't have one. And so the way I've been focusing on interstitial cystitis for the last 18 years is I treat the symptoms. If the symptoms are pain, fix the pain. If the symptoms are burning, fix the burning. If the symptoms are running to the bathroom too much, fix the running to the bathroom too much. I will combine that with a lot of holistic approaches for IC, like dietary management. I give out a lot of aloe vera supplements, or I have people buy aloe vera supplements because aloe vera is very soothing for the urinary system. But then I will also put them down the algorithm of overactive bladder medications, possible InnerStim, and possible Botox for that patient. I have numerous patients with interstitial cystitis where their main symptom is overactive bladder, and this has worked very well for them. I don't want to speak out of line, but I'm going to suspect that the video we heard and listened to, I would suspect that that person had interstitial cystitis. So bladder pressure can mean a lot of things. Bladder pressure is like this, it's this sensation of constantly needing to go. And so there are a lot of people that have this sensory urgency. In other words, they just feel like they have to go, but they really don't have to go. And there's testing that we can do in the office called urodynamics. Urodynamics is like a stress test of the bladder, except I don't have a treadmill. And so we can actually do this test where I can monitor this person's pressure as their bladder fills, and their bladder will be perfectly fine. It'll just go right across, filled nicely, no bladder squeezing, no contractions. But that person is going to be like we'll call it like a cartoon, and they're like water's ready to come out because they feel like they're going to explode. This is perfect for those people because this calms down the nervous system and that S3 nerve to calm down the bladder sensations. Well, I'm new to the area, so so I'm working on it. We're doing well here. We're a new practice in the Sandy Springs area. The building has been open for just under 2 years, and we're doing very nicely because we're able to offer cutting-edge technology like Medtronic for our patients. And if I can be a little, we'll say boisterous, I think our practice, Advanced Urology, is probably one of the largest practices in the country with experience for InnerStim. And so it's very helpful that we do a lot of these, which means that we can guide our patients through this. So Detrol, if you saw my expression. So Detrol is one of those medications that's called an anticholinergic. And so there's numerous of ones on the market. Detrol, Toviaz, Vesicare, Enablex, which a lot of these are generic now. I'm blanking on oxybutynin, which is the oldest one that's been out there. They're all kind of the same because they all have their mechanism of action. The mechanism of action is to slow down the cholinergic system of the bladder, which is a part of the nervous system, to help slow down muscle activity. Like I mentioned in the slides, it's got a very high dropout rate. 60, 70, if not up to 80% of patients will end up stopping this medicine within 6 months because it's causing dramatic side effects. The other thing is the cost of the medication. Branded Detrol, which I don't think you can get anymore, sometimes is not even, or the generic called tolterodine, is not even on is not even on certain pharmacies' formulary. And so, if you may know, if you want to know, the insurances and their pharmacies contract out what they want to use in a period of time with pharmaceutical companies and places that disperse medications like Express Scripts and CVS and things like that. And for example, in 2020, you can have Blue Cross Blue Shield says, well, we're going to allow Detrol, but we're not going to allow Vesicare, and we're not going to allow Enablex. But for all you know, a person may be doing okay with Detrol. The side effects are manageable, their symptoms are much better. But then in 2021, Blue Cross Blue Shield is going to drop Detrol, and they're going to say, well, now we're going to cover Toviaz. So now you got to switch the medication around, and it really becomes a nightmare. So overall, I'm more than happy to try medicine for a person, but I will tell you, it is not my objective. It is not my long-term goal. And my analogy is that think if there was a procedure cure for diabetes. If there was a procedure that would cure diabetes, everyone would have that. That way no one has to live on insulin and metformin and glyburide and all the medications that are associated with high sugars. And that's why it's fortunate in this talk that we do have these procedures like InnerStim and Botox that we can offer people so they don't have to be on medications long term. Oh boy, I think based on the slide, it's around, I mean, if you go by certain numbers, let me see, I'm going quickly here. I think I skipped over this. Oh, there it is. So this slide is based on probably some statistical analysis. There's things called the Farmingham study where they're analyzing people from all over, like the state of Massachusetts. And it says here, 1 in 6. It may not be that high for people in their 60s. It could be 1 in 10, but it's pretty common. It's pretty common. You'll know it because all you have to do is when the world opens up again and we become COVID free and you go to a movie and you go sit in a movie theater, the people who get up have overactive bladder. Or if you're at the ball game and you're in line for food and you see a guy going in and out of the bathroom a lot, hopefully you're not on a long of a line, that guy's got overactive bladder. I mean, you can just kind of watch people. Oh sure, yeah. You can. It's interesting. You can talk to people about how good the bathrooms are where they go. Oh, the mall is amazing. They have wonderful bathrooms on the second floor. Like that's how people think. That's what they have to do. Okay, so 3 different spots. So for overactive bladder, we will look inside the bladder with a camera and inject the Botox in the bottom of the bladder. And we make these little itty bitty injections. They're like 1 cc each. So let's see if I can get you. They're like really tiny. And we just do about 10 to 15 of them. And that's for overactive bladder. In some rare conditions, there are some people where they have what's called high bladder neck activity. So think of the bladder like a balloon. The tube where you're supposed to blow the air in is the bladder neck and the urethra. There are some people that have a high tone in that bladder neck. That bladder neck is staying really tight. And there's some research that shows that you can actually just take the camera back to the level of the urethra, inject it in the muscles of the sphincter, and over a period of time, my lights just went out, and over a period of time, those muscles will relax, like about 10 days to 14 days, and those muscles will relax to help people empty their bladder better. It's a little controversial. It's not entirely known how successful it is. Botox in the pelvic muscles, so those are the muscles that surround the bladder. Those are the muscles that some of them are part of the sphincter, some of them are just part of your pelvic floor. You can call it the girdle if you want. And that is, in Botox in that area, is used for people who have pelvic pain disorders. That's an entirely different subject. That's got its own little world of whether Botox is successful for things like that. I do a little bit of that just because I see a lot of pelvic pain patients, but very different than this talk. DesertHarvest.com. DesertHarvest.com. They're a company out in the West Coast. They've been able to make a freeze-dried aloe vera capsule, and I try to encourage a lot of my IC patients to take it. I'm not going to say what dosing is right because it's a holistic approach, so there's no right answer. But I've had a tremendous amount of success with that supplement. Great. Yes, but we have offices in a lot of places. So we have offices in the Roswell, Alpharetta location, Johns Creek, Decatur, Snellville, Marietta, and we're opening up offices literally any day now, up and coming, Canton and Brazelton. Oh, and we have Buckhead location. Lawrenceville, oh boy, I'm forgetting another. Yeah, we're growing like weeds. It's awesome. It's great. Thank you, Christy. Christy, thank you so much.